Jennifer Chang is well known to most of you as a paragon of Air Force family medicine. After graduating from USU, she trained at Travis Air Force Base and then served as residency faculty at the programs of both Eglin and Office Air Force Bases before coming to USU. At USU, she served as assistant clerkship director and is now clerkship director for the family medicine department. And she also runs the Bench to Bedside and Beyond program for our students who are returning from their initial clerkships. Welcome, Dr. Chang.
Thank you, Mike, and welcome everyone. It's my pleasure to bring you this grand rounds today on a topic that is actually not so near and dear to my heart. This has been kind of a labor of love, built out of I think my own frustration and in the clinical setting. Hopefully you've set up the poll EV. I'm going to go ahead and advance the slide. We are talking about ADHD in adults today. And I'm going to be presenting hopefully some evidence, but also kind of really discussing some of the controversy, maybe some of the underlying discomfort that you may have, as I have had, in addressing this topic in what feels like increasing amounts over, I'd say, the past decade or so, since I've really been in my main clinical practice. In terms of disclosures, I really have nothing to disclose. I don't pretend to be an expert either, but as most of you on this call, we all share the privilege of being the gatekeepers, and we are called to know a lot about a lot. And so I think it's definitely been a great journey for me to learn more about this topic. And I kind of dove a little bit into my why is really, this has been born out of just encountering this increasingly in the clinical setting. And then I also think there's a lot of really interesting things going on in our culture surrounding adult ADHD, and it's and I hope to expose some of that. So I'm going to start out with a case. This is an optional case. It's a choose your patient, 23-year-old undergraduate medical student, or maybe like a 30-ish-year-old graduate nursing student. You can all probably relate to this. Well, those of you at least at USU. The student came in saying they've been having difficulty studying, the long hours, maintaining focus, but they're passing exams, some barely, and overall doing okay. Back in grade school and college, the student really never had to study and was able to pass and do okay. Does report that parents always said he or she was full of energy and could never sit still as a kid. Has been trying to consume high amounts of caffeine to really make studying work. And it's just really frustrated because it's having to often reread, whole paragraphs or whole articles or rewatch videos. And he thinks he might have ADHD. So this is Reflective Practice 401. I'm not asking what would you do. I'm asking you just throw out some initial thoughts, reactions, or emotions that you might have had as you were reading this scenario. And hopefully we'll see some things pop up here on the screen. Somebody is annoyed. Okay, we have a few answers here. It seems like the poll's working. I'm sorry if anybody's having difficulty with it. I'll go ahead and move forward, but I think folks are feeling very similar feelings that I have felt, even seeing that chief concern listed on the ALTA template. Now here we go. Surprised? Nope. Who said? I'm not going to ask. This is anonymous, by the way. I wanted to keep this anonymous. All right. Thank you all. I'm going to move. I'm going to go ahead and move forward. All right, so the next question is, what are your biggest concerns or questions about diagnosing or treating ADHD in adults? And this is just kind of a free text. It's good. We're seeing concerns about abuse, assuming of stimulants. Where are the guidelines? Yes. How long will they be on stimulants? Are there any validated evaluation tools? Did the person have problems as a child? Issues with military service, career. Many of us treat medical professionals, which we can liken sometimes to flyers, to pilots, you know. Are we supposed to be giving medications to those folks? Are they going to have side effects of the meds? Should they be in a high level school if they need a stimulant? So all very interesting questions, and I can relate to most, if not all of those, and I'm going to go ahead and move forward. So I have a lot of objectives today, and there are so many things that I could talk about that I'm not going to be able to today, but I'm going to spend a little bit of time going into a history lesson to talk about the evolution of ADHD as a diagnosis, and then also ask us to consider the burden of adult ADHD as far as, you know, based on the evidence that we have. We're going to apply some diagnostic tools that are available for ADHD and that have been updated for the DSM-5 criteria. We'll go into the risks and benefits of medical treatment, review some of the evidence for the non-medical treatment options, and then through all of this, you know, help us identify kind of a holistic process for the evaluation and management. And throughout all of this, we're also going to be exploring our biases and stigma, because I think this, you know, we've already explored that in a little bit, and a lot of that forms some of the barriers to some of these objectives. So I hope you like history. I think going into the history of this topic has actually helped me overcome some of my own, you know, cognitive biases. But ADHD, we think, was the syndrome known as ADHD was probably first described in the late 1700s by a Scottish physician, Dr. Crichton. And then you can kind of see a timeline here. Really prior to that, any kind of mental issues weren't really seen as medical problems. They weren't really addressed in the medical literature. And then around the late 1700s, we start seeing some literature discussing these diseases, mental disorders, diseases of attention. And then as we moved into the 1800s, there are a lot more literature growing kind of worldwide looking at a variety of mental disorders with a whole host of names associated with them, really focusing on trying to understand underlying causes. There was a lot of association with various forms of brain injury, whether that be at birth or later in life. And then really in the 20th century is when we started to solidify this disorder being kind of a disorder of both inattention and hyperactivity. And you know, several decades ago, more studies, kind of longer term follow-up studies in children with ADHD have supported that there is significant persistence in adulthood. And this Time magazine front page from 1994 probably sparked a lot of visits to primary care for adults wondering, I wonder if I might have ADHD too. In terms of when stimulants were first used for ADHD, that occurred sometime in the 20th century. One of the first uses of stimulants where it was discovered that they had a calming effect on children was by a Dr. Charles Bradley, who was a pediatrician who was a medical director of a children's hospital, or essentially a home for children with various behavioral and psychiatric disorders. And he was actually giving an amphetamine called Benzedrine to children to treat a post-procedural headache, this barbaric procedure called pneumoencephalogram that we do not practice anymore. But he gave it to the children to try to treat their headache. And it didn't really work for headaches, but what he and his staff noticed is that it produced this calming effect on children who were otherwise had significant behavioral problems. And it also actually improved their academic performance such to the extent that these pills were named the math pills in his institution. And one article, you know, what I think of jokingly says that it actually produced a child that fit perfectly into the ideals of industrialism, which is some of that, you know, stigma we see about this disorder. But interestingly, Dr. Bradley recommended the use of stimulants as a supporting role in the holistic management of these children with these behavioral and psychiatric disorders. We didn't really have the diagnosis yet. So it's interesting that even way back when this was first observed, it was couched in the setting of a holistic management approach. And later in the 1930s, public criticism did grow for use of amphetamine in what we call methods of performance enhancement. There were definitely some abuse and addiction concerns. And then later on, we started seeing more regular use of stimulants prescribed mainly by psychiatrists. And then really the first time that ADHD, what we know today as ADHD, was kind of solidified in the DSM was in 1968, where it was called the hyperkinetic reaction of childhood. And throughout the various DSM revisions, the name changed. It incorporated more specifics on different subtypes. But it wasn't really until the revision in 2013 for the DSM-5 that an adult diagnosis was sort of formally accepted in the DSM. And I think what's interesting too, you're kind of seeing the evolution in the medical field, but in our, in popular culture, we see a lot of controversy surrounding ADHD, both in children and adults, just in our lay media and in various novels. So interestingly, this Dr. Hallowell sort of wrote the Driven to Distraction book, which is a very popular kind of bestseller about ADHD. But you can see here, even in 2014, another physician wrote a book basically saying it doesn't exist. And then in 2015, we see a book written called Neurotribes, which actually starts to explore autism and ADHD and other neurodevelopmental disorders as sort of just a form of neurodiversity. And so these are the things that we and our patients are exposed to every day. And really, ADHD there's a huge culture around ADHD to the extent that people celebrate ADHD. You can see a couple of quotes here taken from Attitude magazine, which is an online blog. If someone told me you could be normal or continue to have your ADHD, I would take ADHD. And then down here, it seems odd to call a condition a disorder when it comes with so many positive features. So we're certainly starting to, or some of the literature is starting to view ADHD as kind of this, it is a disorder certainly, but are there positive aspects of it? Absolutely. And again, the culture around ADHD, you can find tons of different blogs. Totally ADD is a very popular one, and I'll show some others later. But really, patients who think they have ADHD or who do ADHD have a lot of support, particularly in the online setting, for finding out if they have the disorder and finding various ways of treating. So what we're dealing with is really a disorder that is oftentimes just a self-diagnosis in adults, and I think that makes it challenging for us. There's also a lot of famous people, really cool people who had ADHD or have ADHD. I mean, who does not want to be like Simone Biles, Olympic gymnast? Dr. Hallowell himself, who I just mentioned, wrote the book Driven to Distraction, is one of those famous people with ADHD. Adam Levine, Maroon 5 star, good old Michael Phelps. And some of you may remember Fonzie from Happy Days, also a sufferer of ADHD. So a lot of talented people claim to have ADHD. So let's move to a second case. And this was a patient of mine from several years ago, a 30-year-old enlisted NCOIC technician. Came to me with difficulty concentrating while studying to complete his bachelor's degree. This had gotten bad enough that he actually turned a few assignments in late and had failed a test. Recalls being a fidgety person on the go and actually says he was treated for ADHD a few years during his early childhood. But in the military has done well, has really liked the structure, hasn't had any disciplinary actions, has a good military record. But came in saying, I'm worried I'm going to fail out of school, and that could potentially affect my career. And so I was wondering about seeking a diagnosis for and possibly treatment for ADHD, but was asking both about stimulant and non-stimulant options. So just want you to think in the back of your head, how would you approach this patient? Do you think they really have ADHD? And what would you do next in your evaluation? And while you're thinking of that, I just want to present some evidence on the burden of ADHD. So for childhood ADHD, numbers are growing, but as of 2016, we think about 7 to 8% of children in the US on average have ADHD, and a higher percentage of those, there's a higher percentage that have ever been diagnosed with it. You see this map here, which I find really interesting, from 2011, showing different distribution across states. And unfortunately, you probably recognize this pattern that we see in other maps of the United States related to obesity, to other markers of health, to social determinants of health. And I find that interesting too. This map very similarly just shows the percentages of children with ADHD who are currently taking medication. So there are about 60% of children currently who have ADHD are being treated for it with medication, and then less than half of those are receiving behavioral treatment. So it's undertreated in children, and we think so in adults as well. Just going to harp again on that pattern that we see in these maps. I can't draw any specific conclusions, but I just find it interesting that in similar areas of the country, we see increased markers of poor health, obesity, decreased vegetable consumption, decreased physical exercise. Is just interesting, and I think reminds us to also think of ADHD in the holistic context of a patient. So in terms of prevalence, currently we think that in US adults age 18 to 44, up to about 5% may have ADHD, but less than 15% of those are receiving treatment. We are seeing increase in diagnosis with the revision of the DSM in 2013. There is a growing prevalence of ADHD in older adults as well. Worldwide rates vary, but mirror the US to some degree. And there is a slight male to female predominance there, although we know in children that ADHD can present differently, and so females may be underdiagnosed. In addition to the prevalence, the impact of ADHD is significant. Comorbid psychiatric illnesses are common. Adults may have as much as a 5-time risk, odds ratio of 5, risk of having depression, anxiety, and substance abuse as well. There is a documented increased risk of suicidal ideation and attempts in adults with ADHD, and there's association with other disorders as well. And there are significant impacts on the quality of life. Adults with ADHD are at increased risk of getting into motor vehicle accidents, and also have overall may have risk of poor or worse educational and occupational underachievement compared to others. And also significant difficulty sustaining relationships in multiple realms of life, whether that be at work, at home, and other areas as well. So it's not insignificant, and we know, I showed you all the famous people that have been very successful, but many of them have also struggled with some of the things you see here, and there's, of course, many others that whose lives are probably significantly impacted. And what about in the military? So this Army resilience survey collected from 2011 to 2013 surveyed about 21,000 Army personnel, most of whom were male. And this was a self-report scale that these individuals filled out. But there were up to 9% showed kind of a significant amount of ADHD symptoms. So these weren't people that were actually diagnosed with ADHD, but had a significant number of the symptoms and could potentially qualify for the disorder. We also know that ADHD can increase risk of deployment-related illnesses, so post-deployment PTSD, major depression, and generalized anxiety. So soldiers with pre-deployment ADHD are at greater risk. And in terms of ADHD persisting into adulthood, numbers vary. There are a lot of different small and large follow-up studies, some of which actually don't show much persistent and others which show up to 60%. One kind of higher quality longitudinal case control study that did a 10-year follow-up on 110 males with ADHD actually showed that about 65% kind of went into remission and no longer actually met DSM criteria, but the vast majority of them still had some level of impairment, even if they didn't have the diagnosis in adulthood. So of those 76%, 35% actually still met criteria. Others met sub-threshold criteria, and others just still had some functional impairment. So we may not know the numbers exactly, but we do know that this persists. And when I get into the etiology later on, I think that will help underscore why that is as well. So in terms of etiology of ADHD, we don't really know what causes it, but we're pretty sure that it's a complex interplay of multiple things. There is growing evidence that this is a inheritable disorder, with heritability studies showing upwards of a 70% heritability of ADHD, and those come from various family, twin, and adoption studies that you can see listed here. We're pretty sure that there's a huge epigenetic component where there's interactions with genetics and environmental factors. There are a lot of kind of gene mapping studies going on right now. I won't go into that, but very interesting. We're seeing a rapid growth in our attempt to understand. We also know from a number of different forms of imaging studies, or EEG, that the ADHD brain is different than the non-ADHD brain. And this has to do with reduced dopamine and norepinephrine transport, decreased brain matter volume, particularly in the frontal lobe. There's thought that there's this kind of delayed maturation of different pathways and overall differences in connectivity. And in the interest of time, I'm going to skip over a video that I was going to show, which really just kind of portrays pictures of those differences. But I just want to get across the point that there's growing evidence that the ADHD brain looks different. And in children, children with ADHD, what they say is, well, there's kind of like delayed maturation of all these areas. So in adults with persistent ADHD, we expect children to kind of grow out of it and for their brains to mature. What about adults with significant ADHD? Are they going to, are they going to see any further maturation after that? And I think that's probably why we see, some of the persistences. Those pathways perhaps didn't mature as we would have hoped they would in a child who had ADHD. So there are a number of studies that have looked at associations with various risk factors for ADHD. For prenatal exposure, maternal smoking and hypertensive disorders of pregnancy has been significantly associated with a child having ADHD. Prematurity, the early childhood environment. There are some studies that show that children with ADHD are more likely to come from lower income and in households affected by poverty, and in households whose parents were less likely to achieve higher levels of education. So even though there's a genetic component, there's a lot of social determinants of health that play into this diagnosis as well, and I think that's very interesting. There's controversial evidence about early toxin exposures to lead. Some studies support it, some don't, but just a whole host of things go into this. I hope what you think so far is that there may be a lot of stigma, a lot of question about whether this diagnosis really exists, but we're seeing a huge growth in our understanding and in sort of the complex etiology of the disorder. And that, I think, for me has helped me recognize, how holistic of an approach I need to take with my patients who are concerned about this. So how do you evaluate an adult for ADHD? We're going to talk about just kind of a simple process you would go through in clinic, and then we're going to talk about the DSM-5 criteria and a few tools that you can use. So, but before we do that, I want to know, what have you typically done, or when do you refer for formal neuropsychiatric testing in the evaluation of adult ADHD? Because I think that's a common question that either we have thought of or we've asked in the past. see about 7 results so far. I know not everyone may be able to participate in the poll. All right. I think we only had 8 responses, but okay. So a couple of folks thought that all adults, or they send all their adult patients for neuropsychiatric testing. Several are unclear, and several kind of rarely do it. And we'll talk a little bit more about that in a second here. So just like anything in medicine, you always want to start with the thorough history, and particularly for a self-reported diagnosis like ADHD, you definitely want to do that. You really want to get a full sense of what are the patient's concerns, a very thorough history. We don't often ask our patients about their childhood illnesses. I mean, we teach the medical students too, but I don't know how often I do that. But you really need to dive into their childhood history, were there any kind of developmental concerns, ask about family history, and then if you can get some corroborating information in an adult, maybe from a spouse, a family member, someone else, that can be helpful, but it's sometimes harder to do that in adults as compared to the diagnostic process for children. You definitely want to ask about social history and habits, and also medication use. Folks may be taking a variety of medicines or supplements that actually cause side effects that can look like ADHD. And then you absolutely want to apply some validated screening tools, not only for ADHD, but for many of its comorbidities, because I think at least something we might tend to jump to a conclusion is that, oh, if someone's coming in for ADHD, they must be anxious, they must be depressed. Well, it could be true. They might have both ADHD and one of those things, and oftentimes they will. So you definitely want to use several screening tools. And then in terms of getting other objective data, sure, do your physical exam, a focus exam, maybe some labs, maybe you need to check a thyroid or whatever you feel is clinically indicated. But for neuropsychiatric testing, the evidence isn't that strong that it's helpful. The problem with it, as per my understanding, is that you just can't get there's no neuropsychiatric test that says this person has ADHD. What it will show is folks taking it will have various abnormalities in various domains, but there really isn't a solid way of saying, okay, this person has ADHD. So it's really not considered necessary, but certainly if you think other things may be going on, other learning disabilities, it could be useful. And I saw we have Dr. Lane Benyon here with us today, and I think maybe Dr. Schneider too, that we'll have some discussion a little bit later. So I appreciate them being here. So, so that's a basic process. And then you want to make sure you're applying the DSM-5 criteria. And just by way of review, I know we probably all know this, but the essential features of ADHD, both children and adults, is that it is a persistent pattern of inattention and or hyperactivity, impulsivity. It does interfere with function and development and really should do that in more than one domain. By definition, historically, it begins in childhood, and it still does by definition, but it's not required to prove, it's no longer required to prove that you had it in childhood in order to have the diagnosis. And comorbidities are common, so keep those in mind. So the revisions to the DSM-5 that have really aided in the diagnosis of adult ADHD are that they extended the childhood age. So in DSM-4, symptoms had to be present before the age of 7. Now in DSM-5, symptoms just needed to be present before 12. You don't have to have the diagnosis, just had to have symptoms. It also allows for this comorbid diagnosis of autism spectrum, because we do know that those correlate often. And then for adults, it requires fewer symptoms than children. So previously, and for children, it requires a minimum of 6 symptoms in a certain category for the diagnosis, but now for adults it's 5. And it's been recategorized. There's a whole section now on neurodevelopmental disorders, and that's where ADHD has been put. All right, so we're just going to review that really quick. So remember too, the symptoms should have been ongoing for a minimum of 6 months, and an adult should have either inattention or hyperactivity or both, 5 or more of any of these symptoms. And I know for me, when I read through this list, the first thing I think is, I kind of do that sometimes too. But an adult with ADHD should really have 5 or more that persist for 6 months in more than one setting. And for hyperactivity, it's a person who tends to fidget or squirm, leave their seat, can't engage in leisure quietly, always on the go. You can read the slide here. You know, some of these are really overlapping, but again, should meet at least 5 or more criteria. And then remember, they must have had symptoms that onset before the age of 12, and it really can't be better explained by another disorder, particularly a disorder with psychosis or another significant mood or anxiety disorder where you think that's the predominant condition. So other features of ADHD in adults that aren't necessarily clearly outlined in the DSM chart are that inattentive symptoms in adults tend to persist more from childhood into adulthood, and hyperactivity and impulsivity probably doesn't persist as much, or it comes out in other ways that we don't label as that. Emotional dysregulation is common, and inattention in adults might look like things like starting a task without reading or listening to directions, and then difficulty doing things in a proper sequence. Impulsivity may actually look like just excess speeding, you know, either having motor traffic violations or potentially accidents as well. So I love this meme because, again, when you look at all those symptoms, a lot of us struggle with those from day to day here and there, especially today. We're in this period of the information age. We always have information overload. We're all task saturated. And really, for some of our patients that I've already mentioned, they are coming from a different realm of their life where now they're sitting in the fire hose of medical education, undergraduate medical education, or our graduate nursing students have been working on the wards for years and are suddenly in this new environment where they're having to study all the time. So sometimes I wonder, is it the diagnosis or is it just that your situation has changed? And probably the answer is true in different scenarios. So in terms of your validated screening tools for ADHD, there are a number of them, but the most easily accessible are going to be the Adult ADHD Self-Report Scale, which has also been updated for DSM-5 level. Again, I'm just showing you this list from the AAFP National Research Network. There are almost 10 different items on there. This Wender Utah rating scale is actually available as an online app that I'll show you as well. So this is probably the most easily accessible scale, the Adult Self-Report Scale. It consists of 18 questions, but the first 6 are most consistently considered, if you screen positive on part A, the first 6 questions, that is considered a positive screen that could indicate you have ADHD. The part B symptoms, 7 through 18, are just really supportive information. This scale has been updated or sort of adjusted for DSM-5 and has some similarities in terms of the questions. The scoring for this one is a little bit kind of harder to figure out, is a little bit more proprietary, but essentially it kind of follows a similar pattern of the DSM-4 based self-report scale. So if you're really not sure and you need to get something quickly, just go to the DSM-4 based self-report scale. It has been validated and can be useful. Again, it's a screening tool. Doesn't mean they have it, but it means they screen positive and you need to potentially do more evaluation. And here's this Wender Utah scale, which you can get through MD app, where they can actually fill it out online. In addition to the screening tools, there are also more in-depth diagnostic tools and quality of life assessments, which again are important to really help you understand what's the level of impairment for a patient, and particularly to use if you're trying to differentiate ADHD from another diagnosis. So the bottom line really in the evaluation is that you need to be thorough and don't rush. Oftentimes these students come in and they're really frustrated and you only have 20-30 minutes to see them and they think they want to walk out with a stimulant that day. There's really not a reason to rush this. Stick to your DSM-5 criteria and definitely think about your comorbidities. So I'm going to move to another case now. This is an interesting one. A 35-year-old active duty officer who I had a number of years ago presented for an Adderall refill. I'd never met him before. He'd actually started taking it several years prior when he was studying for his master's degree. And actually he's pretty sure that he had ADHD in childhood, but it was never diagnosed. I don't remember exactly where he got out the Adderall from. I think it was from a psychiatrist, but I'm not sure. But he found it helpful during long periods of sitting writing speeches for work. He was actually a chaplain. And just found it impossible to really get his work done without it. There were no concerns for misuse. He always seemed to have all the prior appropriate refills looking back into the medical record. So I'm just curious as what you think you would do in this case. So I'm going to ask you on a poll, what do you think you would do if you had been faced with this patient? Just a free text answer. Looks like folks would refill, try to get more background, refill and move on. Okay. Thank you for sharing that emotion. I appreciate that. Refill somewhat begrudgingly. That's kind of how I felt too. All right. Thank you. I'm going to move forward. Appreciate that. So we're going to talk a little bit about treating adult ADHD, and then I'll come around to some of the controversy in that case here in a few minutes. So treating ADHD, you need to know what your goals are. We'll talk about some of the modalities, what outcomes we're looking for, and some of the available guidelines for treating ADHD. None of which are in the U.S., by the way, which I think is part of a symptom and a problem we have with managing the disorder here. So your goals are going to be to improve symptom, but ultimately it's to optimize their function. And but also remember, you got to think about comorbidities, and you want to manage those as well. In adults and really in children beyond the preschool age, most of the guidelines say that stimulants are first line. They don't say they're the only thing to do, but stimulants are first line for treating adult ADHD. In adults, most of the guidelines recommend an extended release formulation or a long-acting formulation. It's thought that they may decrease risk of abuse, although it doesn't make it impossible. And then the immediate release or short-acting formulations can be used, but in a little bit more of a targeted way. As you all know too, there are some non-stimulant medications that we sometimes use, particularly in children, either as alternatives or as adjunctive medications when stimulants either haven't worked or haven't worked adequately. And then there are some off-label use of antidepressants in adults, particularly we think of bupropion or Wellbutrin, and then the TCAs as well have been used for adult ADHD. I know this is a busy chart, but this comes from a really nice New England Journal of Medicine review on the treatment of ADHD that came out very recently. And if you remember back to the ADHD brain slide that I showed about the underlying structural and functional problems that are happening in the ADHD brain, this is probably why stimulants help. The amphetamines, the stimulants increase levels of dopamine and norepinephrine transport. So it's thought that's how they work. And then some of the non-stimulant medications either have other effects that sort of stabilizing or activating certain pathways, or decreasing certain other disorganized pathways in the brain, or at least that's how we think that they work. So in terms of benefits and risks of pharmacotherapy, ADHD medicines do improve ADHD symptoms, and has been shown, whether it's patients reporting or in other studies, that they improve overall work function. It may actually result in healthier driving behaviors, reduced criminal behaviors. So there are a lot of positive effects of pharmacotherapy for adult ADHD. But you've probably also had some patients from time to time that actually felt like the medications caused maybe a loss of sense of self. Maybe they were worried about the stigma associated with medication use. Particularly our active duty patients often at times are worried and probably should be worried to some degree. Sometimes the stimulants, if they're not taken at the right time of day or you don't have the right dosing, might cause insomnia. And you can see increases in blood pressure and heart rate, although not often significantly like we sometimes worry about. And really, some of the underlying challenges that we do have some short-term outcomes-based data, but really no long-standing, long-term outcomes data. Medication discontinue rates are high, particularly in children, but really at all ages, and kind of the peak of discontinuation in adults happens at around the 5-year mark. And then, of course, an underlying concern that we all probably often have is there a concern for misuse or diversion? Oh, this cross-sectional online survey of adults who had ADHD actually gives sort of a patient perspective of how they felt that stimulants helped. And overall, there were high satisfaction scores from patients saying that the stimulants definitely reduced their symptoms and they felt like they were functioning better. But most of the patients in this study still reported some persistent impairment at home, work, and in relationships. And even though there was good satisfaction, one of the predominant concerns was that the duration of effect was often not adequate, particularly in the evening hours. My overall conclusion from this small survey study was, and from others as well, is that stimulants, they do help, but this is a disorder where there is impairment. I don't think we should expect stimulants to 100% reverse all the impairment, and I think it just further highlights that we truly are dealing with a disorder, and the stimulants are just helping to improve function. Similar to managing chronic pain, we may not expect 100% pain relief, we just expect to improve our function. One of the things they highlighted here, though, that we see commonly, though, is with if the duration of effect is a concern, if the meds seem to be wearing off in the evening, oftentimes you may see a pattern where a patient is on a long-acting stimulant that they take in the morning with a short-acting, low-dose stimulant given at lunch or in the early afternoon to kind of help tide them over for the evening. And I've certainly used that regimen before. In terms of, interestingly, in terms of adverse effects of discontinuing medications, we don't have a lot of data, but this meta-analysis in both children and adults actually showed that quality of life scores went down in children and adolescents who discontinued medications for ADHD, but we didn't really actually see much in adults. And I think this study had was looking at a larger number of children than adults. So in terms of, do we see evidence that stopping medications causes impairment? We don't see the evidence. We suspect that may be the case. But interestingly, too, relapse rates were actually high for significant for all groups. So, this. If someone makes it to adulthood with ADHD, there's unfortunately a chance that they may not grow out of it and it'll become a lifelong disorder. Now, in addition to pharmacologic treatments, psychosocial interventions are really big, particularly in children, and really are a mainstay of therapy, even if you are beginning with stimulants. But these really should be part of the treatment of adults as well. I think sometimes we think adults, well, I know what to do, I'll just take my medicine and I'll figure everything out. But we really should be utilizing cognitive behavioral therapy if available. And then there's also kind of this new growth in what we call ADHD coaching. You can actually go online and find an ADHD coach that provides a little bit more kind of individualized assistance with achieving specific goals and is accessible. But this should really be a part of what we're doing. I don't think we should just be handing out stimulants all the time. Unfortunately, though, the evidence for non-pharmacologic treatments isn't quite as strong as it is for stimulants. That's probably no surprise to anyone. And part of that is just by the nature of the therapies themselves, and these are not overnight fixes. These are things that really need to be maintained over a long period of time. So not a lot of evidence to support, but certainly not evidence that there is harm, and it's probably something we should be considering. And then remember back to those maps that I showed, there are a lot of things that go into this disorder. Probably some social determinants of health, childhood habits, other habits. We need to be, just like good primary care doctors, we need to be taking a holistic approach to our patients and working on sleep hygiene, exercise, healthy diet, all of those things as well. And we do know, despite the evidence, despite availability of long-term data, we do know that treating ADHD results in improved symptoms and improved function, and hopefully decreases the risk of comorbidities. All right, so kind of going back to those two cases, that 23-year-old medical student struggling to focus, and that 35-year-old active duty officer who uses stimulants to write speeches. One of the questions you probably are asking is, okay, it sounds like these folks may have some features of ADHD, but are we really treating ADHD? And there is evidence to support that stimulants are used oftentimes for non-ADHD purposes, or in people who do not truly have ADHD, and so they're used for performance enhancement. And this small cross-sectional survey study was actually of South African medical students that showed out of the 540 who were surveyed, a decent percentage of them were using stimulants, and most of them did not have the diagnosis of ADHD. And so there's we see this. I didn't find any data in the U.S. in U.S. medical students, but I wouldn't be surprised if we see some of that. This small cross-sectional study of attitudes in medical students, I'm not sure which country this was in, a smaller study, did show that a great number of them were concerned about the fairness of stimulant use for performance enhancement, and as well as the harms. And then this very large systematic review of over 40 studies with probably tens of thousands of folks surveyed, who included basically anyone in the public, but included students, parents, physicians, general public, kind of looked at these overarching concerns and themes about stimulants for cognitive enhancement. And there's definitely concerns about the safety, about use of stimulants as a form of coercion. So students feeling that they have to perform a certain way, and they've got to get the stimulants to achieve their goals, as well as fairness on that line. So, some of the underlying questions that we really have in adults is it really ADHD? Am I just treating for performance enhancement? If the latter, which I suspect I've done for my patients before, is it okay? Is it fair? And are there potential harms? I won't be able to answer those questions today. I think it's a really, again, a controversial topic, but one thing, if you are prescribing stimulants, I think we all absolutely must, and we have to limit our prescription and track renewals. And we know that, at least in our formulary, you can't give more than a 90 to 100-day supply of stimulants. In adults, preferentially use extended release formulations when you can. You do have the option of doing random urine drug screens. We don't do that in our active duty patients, that they get called to the golden flow, as part of regular screening. And then talk to your patients about the risks of diversion. Don't just quickly ask or assume that they're not misusing them. Ask about it, and then also maintain frequent follow-up as well. Other medical cautions with stimulants, you want to use caution, especially if you're treating older adults. If someone has underlying cardiovascular disease, you probably should do an evaluation before starting a stimulant. Anyone with a prior history of a seizure disorder or a psychotic disorder, definitely take caution. I would get my psychiatry colleague on board there. And then also probably a no-no in pregnancy, and maybe in lactation. I know we're kind of running a little bit short on time. I am almost done. I'll share this one last case of a 34-year-old spouse who worked from home. This is a patient of mine. She had a baby 6 months prior and had just started working from home again, but she had a full-time job on the computer a lot, lots of conference calls. She'd actually been treated for ADHD in her teens and in adulthood, but she had stopped all her stimulants completely throughout her pregnancy. But found it very hard to be productive during her pregnancy. At the time she was seeing me, she was still breastfeeding, but thought, I probably need to get back on my stimulants. I'm going back to work, and I need to be productive. When I saw her that day, of course, she also screened positive for some postpartum depression and anxiety. So what would you do? Would you restart stimulants, or would you angle towards the comorbidities? And I definitely, in that case, angled towards the comorbidities first and got her started on treatment more for some postpartum depression. She ended up weaning off or stopping breastfeeding and ended up getting back on her stimulants. But that was a good reminder to focus on the comorbidities first. In terms of use of stimulants in pregnancy and lactation, the general recommendation is just to avoid them. There is some risk association in pregnancy that there may be a risk of an induced abortion or miscarriage, possible adverse fetal outcomes. As with many medications in pregnancy, we just don't know most of the time. In terms of lactation, there is evidence that stimulants do transfer to breast milk. That might be lower risk for the immediate release formulations, but we tend to want to use extended release in adults. So again, I would use caution there, but we are seeing increased rates of stimulant use in women who are breastfeeding. All right, so as we come towards the conclusion here, I don't know how you're feeling now, but if you thought that adult ADHD might be fake news at the beginning of this lecture, maybe you feel a little less so now. I personally do love this meme, though. You just got to wonder, is it really a disorder sometimes, or are there other factors at play? I'm going to skip over this poll. I was going to ask you all to rate whether you thought that was true or false, but we're running low on time. So, but this, in the last few slides, I just want to talk a little bit about the barriers to addressing ADHD in primary care, because there's a lot of our bias and stigma is rooted in just, the complex nature of the disorder and just in lack of training and education. This was a large mixed systematic review of beliefs, attitudes, and knowledge toward ADHD among mostly primary care physicians, not only in the US, but in other countries, included over 48 papers. And the pervading themes were that there's a lack of training and confidence. Over 75% of the studies, that was kind of the biggest factor. There's persistent, misconception that, ADHD, it only happens in boys, it's a result of bad parenting. And then truthfully, concerns about time constraints with the need to do a complex evaluation or a thorough evaluation. There really just isn't time in a simple visit. And then also concern about the lack of quality assessment tools, which that is changing. This older survey of primary care physicians in 2009 just kind of highlighted some of those tendencies, that lack of confidence, some believing that there's no clear criteria and not even sure that the diagnosis existed. That was back in 2009. A more recent survey in 2019 that kind of compared primary care physicians to psychiatrists still showed some persistent lack of confidence, concern about, not being sure of the diagnosis, an increased tendency to refer. Even though we're seeing, increased evaluation of this in the primary care setting and treatment, there still is discomfort with it. So there are a number of wonderful patient and physician resources that are readily available. Oftentimes our patients are going to come to us with maybe more information than we have about the disorder. I particularly have enjoyed getting onto the CHAD website, which really has a broad array of resources for both patients and providers. This Attitude magazine, actually, this online blog has a podcast that I'll show, this ADHD experts podcast that you might find interesting coming from the provider perspective. But there's all kinds of podcasts and a whole host of resources available. In terms of practice guidelines, like I mentioned earlier, we don't have any in the US, but Canada, the UK, and the European consensus all have some guidelines. And very much kind of mirror what I've presented today, this holistic approach, this use of validated screening tools, use of stimulants first line, but also very much taking into account the concern for comorbidities. So as I close today, I just want to reiterate that our understanding of this disorder is growing rapidly. We're also seeing that there's a significant burden of adult ADHD. We have some screening tools available to us, but we really need to be thorough. We need to assess for comorbidities and be forthright with our patients in terms of the lack of evidence for long-term outcomes of treatment. And so we really must all take a balanced approach. So again, my bottom lines here, and I'd like to open it up to questions and discussion, particularly to see if Dr. Benyon or Snyder wanted to comment. Because here at USU, we are so fortunate to have a counseling center and many resources to really aid us in the diagnosis of these kind of unclear cases with students. So I will conclude with that. Thank you.
Just to open the discussion, this is Lane Benyon. Those of you who I haven't interacted with, I'm retired Air Force and worked as a neuropsychologist in that capacity. Thank you, Dr. Chang. Excellent presentation and overview. Just to highlight or reinforce some of the things that she mentioned. Unfortunately, neuropsych testing, there's a smattering of studies that occasionally, some of them find differences, some of them don't, in executive function, in some working memory tasks, some of the other tasks, paced tasks, but it's not, unfortunately, it's not persistent enough, or I should say consistent enough. And when they do find a difference, it's a relatively small effect size. One kind of test that you didn't mention is the computerized continuous performance tests. There's a fair amount of usefulness in my understanding for children and adolescents for that. In my understanding, it's somewhat less useful for adults. And perhaps that's not surprising because most of these were developed and built to help the diagnostic process in children. One additional part that in preparing for this and some of the other work that I've done working with individuals, there's a small set of studies that are looking at individuals with high IQ or above average IQ and ADHD. And I think we have to be a little bit careful there because the vast bulk of the studies are looking at individuals with average and many individuals, children in particular, that are studied with ADHD, they have lower than average IQs. So we have to be a little bit careful there. And I think my read of that handful of studies is that there's some basis for saying that individuals with higher IQs may compensate for some of those difficulties. And that's where some of the controversy comes in as they go into college or medical school or graduate school. They're now coming forward because they're having more difficulty performing at that level, whereas before they were able to compensate. So thank you, Dr. Chang, for inviting me, and happy to stay on for additional discussion or comments.